Hello, everyone. Welcome to our March ICARE case conference. So with that, I was going to shift over to Meredith, who's going to present our first case, after which I will introduce our preeminent guest speaker today, Dr. Ben Park.
Hi, I'm Meredith. I'm one of the cancer genetic counselors at Vanderbilt, and I am going to present a case. So I saw this patient probably a year ago, 37-year-old male, and he came in because his sister had recently passed away from a rare aggressive cancer called a nut carcinoma or NUT carcinoma. I'd never heard of this cancer. So it led the patient to pursue multiple liquid biopsy tests. He has no personal history of cancer. There was no other family history of cancer, but the visit was prompted by his sister's sudden passing. And before he came in, he was messaging back and forth with us. And I just wanted to read what he had said in one of his messages because I thought it was really interesting. The reason for my visit is to discuss the RGCC, so that's the test he had, or the company, liquid biopsy, and the report is attached. The liquid biopsy shows positive circulating tumor cells in my blood with the cell's phenotype biomarkers and tumor stem cell markers and many other cancer markers turned on. RGCC explained to me that malignancy was definitely detected. My sister also died last year of cancer at age 37, so I believe I may have genetic risk factors. Considering all of this, I'm concerned that cancer may be growing somewhere in my body. The next slide will show the test report. I'm sorry, my slides aren't advancing. So this was one of the test reports, OncoTrace, and then the second was OncoGenomics Plus. And we had actually talked to Dr. Park before we saw the patient just to make sure, there wasn't something that we should be focusing on with this test report. So we really took the angle with our genetic counseling visit that, testing we could offer doesn't detect circulating cancer. It looks at inherited predispositions to develop cancer. He didn't have any family history, but decided to still go through with genetic, or besides the sister, decided to go through with genetic testing. We didn't find any inherited cancer risk. We incidentally found that he's a CFTR carrier. But just thought this was an interesting case because I think these are coming more and more. Patients are getting these at-home tests and bringing them in with a lot of concern.
So with that, I wanted to introduce Dr. Park. Thank you, Meredith. And the other thing I will mention about this case, which Meredith knows better than me, is that this patient was being told that she had, or that he had some form of cancer, and to get repeated tests at his own cost. So again, I think this brings up a lot of issues. So Dr. Ben Park is our guest expert today. He's the director of our cancer center here at Vanderbilt. He's an internationally renowned breast cancer expert and pioneer in developing approaches for studying circulating plasma tumor DNA and the use of liquid biopsies for cancer therapy, hence the reason for him being our literally one of the world experts in this area. First to identify the high frequency of PIK3CA mutations in breast cancer, discovering their contributions towards oncogenic phenotypes, and has also made many other fundamental contributions. So Ben, I'm going to turn it over to you to comment on the case and then to go on and teach us.
Yeah, no, I'm happy to, and thanks for the generous introduction to. I think the case was something that I remember. I dug out that old email that I was not holding back in my disdain for these types of tests because they have not been vetted, they have not been validated, and I think Tua kind of alluded to this. I think it really preys on the fears of people who have had loved ones with cancer, and particularly in this case, where this instance where a young gentleman is very, very nervous because of his sister's history that he might have cancer. And then, to me, it's really not responsible to tell someone that they have cancer when there's no validation behind that and then say, oh, you have to keep coming back for more. And so my personal belief is that we are working towards that goal, but we're just not there yet. And some of it I'm going to talk to you about today. All right, so I'm a breast oncologist. I'm actually going to use this talk to highlight some of the work that we and others have done in the breast cancer field, but really this is a paradigm that can apply to many, if not all, solid tumors. By the way, I love puns, so forgive that first title. These are my disclosures. And many of you probably already know this in the audience, but breast cancer is a huge health problem in the United States with close to 300,000 cases, new cases diagnosed each year. The majority of breast cancer patients, however, in this country will be cured. But because of the magnitude of the number of cases, 40,000 patients will die from the disease. And when I see patients for the first time, I kind of like to put it into two broad stroke categories that we have early stage, which is curable, and metastatic disease is not, although it can be treated and in some cases even converted to a chronic disease, similar to what insulin has done for diabetes. But I think it's really important when I see a new patient to go over what the goals of systemic therapies are. That's what I do as a medical oncologist. So my surgical and radiation oncology colleagues, they're the local therapy doctors, and they actually cured the majority of patients with local therapy. We are kind of the cleanup crew, is what I like to say. By offering systemic therapies in the metastatic setting, we can prolong life and treat symptoms, as I mentioned. But most of our work is actually being done in the adjuvant setting. So we are adjuvant, meaning kind of secondary therapies. And here we are called in to make educated guesses about who may actually benefit from additional systemic therapies. And what we're really trying to do is eliminate micrometastatic disease. That is disease we can't see, but based upon the features of the tumor, the patient's age, and the stage. Again, early stage can be 1, 2, or 3. So the higher the stage, the more likelihood of having micrometastatic disease that will come back. And that's how we make decisions to who gets additional adjuvant systemic therapies. And to put some flavor behind this in terms of the magnitude, 150,000, probably more now, patients in the United States alone are candidates for these adjuvant systemic therapies every year. So you might ask yourself, well, how do we really know this works? We're talking about micrometastatic disease, which means we can't see it by clinical exam or by CAT scans or any other type of imaging. And we know because of these long randomized controlled clinical trials that take patients who are closely matched for stage, age, and type of breast cancer. And then in one group, they get chemotherapy, and in another group, they do not. And if you follow these patients out years to decades, you can actually see that there's an impact in the number of patients who are disease-free and alive without breast cancer. And we used to have this tool called Adjuvant Online, where at 10 years, you could say, oh, this is the green bar. These are the number of patients in this example who would be alive with just doing surgery alone. And then about a third are going to succumb to cancer. Whereas with chemotherapy, the benefit, another 12.6% or 13%, will actually be alive and presumably cured of their disease. So that comes at a price. If you look at the blue bar, death by other causes, it is slightly increased in the group that gets additional systemic therapies. But probably the biggest conundrum of this approach is that we don't know, or I don't know when I see a patient for the first time after surgery, does that patient really have microscopic disease or not? And because of that, we end up over-treating, and we never know who is really cured or disease-free or will be disease-free for the rest of their life versus those that are not. And that's highlighted here. This is probably, I think, the biggest unmet need with our current paradigm in the adjuvant setting. We don't know after surgery and or radiation if a patient falls in the green bar and gets chemotherapy. Again, that's the majority of patients. Or even if they do need chemo because they have micrometastatic disease, which bucket they'll fall into. Is it going to actually be a benefit in the yellow, or is chemotherapy going to be ineffective? And this really applies to all of our adjuvant systemic therapies with very few exceptions. And our kind of thought process on this is, wouldn't it be great if we had some sort of microscopic lens or test that could tell us whether or not patients truly have what we call minimal residual disease or micrometastatic disease? And that would allow us to really say with a high degree of certainty who is cured and who is not. In some ways, as I'll show you, would also influence how we could get new drugs to patients faster in the adjuvant setting. You could imagine if this is a good enough surrogate marker, we don't have to wait years to decades to see if an intervention is actually effective. We could use the presence or absence of ctDNA or micrometastatic disease. And so this has kind of been our shtick for the last decade or more, is that if we could develop blood tests that could detect microscopic disease, we could really change the whole paradigm of how we do systemic therapies. So this is a very simple concept. If a patient has a breast tumor, as denoted here by this black dot, that patient should have a blood test that's positive for what we call circulating tumor DNA. And I'm going to get into the next slide what that is. On the other hand, after surgery, if that patient falls into the majority of cases where that patient is cured, then the ctDNA would be negative. And then conversely, if that patient still has microscopic disease in the body, that would be a positive result on the blood test. And importantly, because this is also quantitative, which I'll get into a little bit later, one could even measure with serial sampling whether or not our therapies are working. Again, getting into the yellow versus the red bar in the prior slide. So what is ctDNA or plasma tumor DNA? There's been a lot of different monikers and abbreviations, but essentially nowadays there's probably more uniformity that what we call circulating cell-free DNA is really referred to as cfDNA. Turns out all of our cells in our body shed these little tiny fragments, we call it naked DNA, into the circulation. And we don't really know if this has any function. Most people think of it as just waste product. I've been known to call it cellular poop because that's kind of what it is. And it gets cleared out in the liver and the kidneys. ctDNA, on the other hand, is a subfraction of total cell-free DNA. It's the cell-free DNA that's coming from the cancer cells, as denoted here in the blue. Because cancer is really the result of DNA mistakes, mutations, and also what we call fusions and other types of DNA changes, those changes are reflected when they secrete out their ctDNA, and that's depicted here. And so essentially, we can draw a tube of blood or tubes of blood, spin out just the plasma. Used to be serum or plasma was used, but we and others show plasma is really a superior analyte. And then find those DNA pieces that represent from the tumor, because we can actually do what we call next-gen sequencing. Now, despite what this diagram shows, this is not so easy. We've known about cell-free DNA literally for decades, but it wasn't until recently we had technology to actually pluck it out and examine it. And that's because, unlike this picture, this is really, usually ctDNA is infinitesimally small portion of the total cell-free DNA. And it is the proverbial needle in a haystack. And so we wanted to do both metastatic and early stage breast cancer patient studies when we first were getting into this field, again, probably well over a decade ago. This is when I was at Johns Hopkins, and I'm not going to belabor this. This is published. It's pretty old data, but it really was kind of the big proof of principle study for us. We just collected any tumor tissues and blood samples that we could from women with early stage breast cancer diagnosis, just all comers. And we got 29 patients. We had 29 pre-op bloods collected. So this is after they had their biopsy, but they still had cancer. And then we actually got the tissues as well as post-op bloods. We were only successful in collecting 17 of the patients. Hopkins, like Vanderbilt, is a tertiary care referral center, so many patients just come there for their surgery and then go back home or elsewhere for the rest of their management. Again, I'm not going to belabor this, but essentially we just look for, with old technology, 2 mutations in a very commonly mutated gene of breast cancer, what Dr. Pollock called PIK3CA. And so I'll just highlight that in the red, these were patients who still had persistent ctDNA post-surgery. Now, some of these patients hadn't had the radiation yet, hadn't had their endocrine therapy or chemotherapy, and almost all the patients except for 2 were hormone receptor positive, HER2 negative, which is a disease type that tends to recur nowadays much later than 5 years, or it can, I should say, recur much later than 5 years. But I will point your attention to patient 5. That was a triple negative breast cancer who had cleared her ctDNA, and at the time of evaluation in 2017 had no recurrence. On the other hand, this was a patient who had a fairly high percentage of ctDNA. 2.9% is actually considered fairly high. Got surgery, got chemotherapy, and in fact, this was a very aggressive type of triple negative breast cancer. So this patient got scanned and did not have any evidence of metastasis, and then started her adjuvant chemotherapy and still had persistent ctDNA by this test. And unfortunately, that was somewhat prognostic because in about 2 years, she did eventually develop widespread metastasis and succumb to her disease, unfortunately. Heather Parsons was a fellow of mine at Johns Hopkins. Again, it makes me very proud, like a dad, but also feel very old that she is now very successful as a breast cancer oncologist at Dana-Farber. Also, continuing her work in cell-free DNA and ctDNA studies. And so she actually presented this recently, I think it was either San Antonio or ASCO, but this has been published and it was a really great example of what ctDNA might be able to do in the future. So these are, again, hormone receptor positive, HER2 negative breast cancer patients. So many of these patients will relapse later in their course of their lives and disease. And so Heather actually, with her colleagues, took blood samples from patients who were at least 5 years out from their initial diagnosis, and then just collected serial blood samples. And as you can see here, for the most part, when they detected something, there's only 8 patients, it's a very small study, those patients ended up developing real metastatic recurrence. They did miss one patient that was ctDNA negative that did also have a recurrence. But this was really, albeit again, a very small pilot study, but really exciting that we could potentially use this as a serial monitoring marker in the future. Now, I'm going to take a half step back and go off script here, because one of the things that I'm always beating my chest about is the difference between clinical validation and utility. And it kind of goes back to that case, which I don't think has been validated. We have enough validation now in breast and other cancers using ctDNA, meaning that we can correlate that if you're ctDNA positive, that usually means, just like in Heather's study, that something's going to recur. What we don't have is utility studies yet. And that means, okay, if we can detect ctDNA and there's enough lead time where perhaps it's still microscopic disease, could we throw drugs at that patient and actually cure that patient still? That's kind of what we really want to do in terms of a positive result. And we're just not there yet. We're doing those types of studies, both here at Vanderbilt and across the nation, but we just don't have those results yet. On the other hand, there's something that we call the negative predictive value of these tests, which isn't quite there yet. But that's the idea. If you are negative, does that truly mean you're either cancer-free or clinically cancer-free? Because there can be a subtle difference. And is that a patient that we wouldn't actually worry about having recurrent metastatic disease in the future? Neither of those two have been proven. This is kind of the holy grail of what we're trying to do in this particular biomarker space. Now, neoadjuvant chemotherapy, I'm sure many of you know this, is chemotherapy and other systemic therapies that we give before surgery. So a patient will get a biopsy, they get a diagnosis, and we give them chemotherapy and other systemic therapies ahead of time with the goal of trying to shrink the tumor down to nothing. This is really only in triple-negative breast cancer patients and HER2-positive breast cancer patients, where if that happens, we call it a pathologic complete response, or PCR. And that is a highly favorable prognostic marker, meaning probably 80 to 90% of those patients are going to be cured of their disease. This kind of makes sense, right? If you think about, oh, it works so well in the primary tumor and the surgeons went in and the pathologists see nothing. If there was microscopic disease, that kind of tells us that it was very sensitive to the chemotherapy regimen. And these are typically stage 2 and stage 3 patients, so they do have a high risk of relapse. This has now become a surrogate kind of endpoint for new therapies to get faster FDA approval. And there's some drugs that fell into this category recently. And residual disease now, so let's say a patient doesn't achieve pathologic complete response, all is not lost. There are still a number of those patients, in fact, a fairly high number, that will be cured, but they are at higher risk for relapse. And now we have data to suggest, again, getting back to clinical utility, that giving those patients additional therapies after their surgery. So it's a lot, right? Get chemotherapy up front, surgery, still have residual disease, you're going to get more therapy afterwards in the terms of chemotherapy and now immunotherapy. All right, so we had the idea, gosh, many years ago now, and Heather Parsons, when she was in my lab, wrote this study. Could we actually use a blood test to offer a no surgical option? You can imagine the surgeons in our group were thinking I was crazy when I pitched this. But the idea here is, if you have a pathologic complete response, you haven't therapeutically really done anything for that patient, removing dead cancer cells and healthy breast tissue. And so the idea would be, if we could actually get a great marker that could predict for pathologic complete response, then maybe we could offer a no surgical options for patients in the future if they wanted to do so. And so that's the idea. Again, if you have a tumor, you get upfront neoadjuvant therapy. If your ctDNA is negative, again, recognizing that we need a really high negative predictive value, then that, if it correlates with pathologic complete response in the future, we may be able to offer a no surgery option. On the other hand, if that patient still has ctDNA positivity, regardless of path-CR or not, I think that those are patients at higher risk. And so we are studying that right now. That is patients who have residual disease and ctDNA positivity, or have PathCR and ctDNA positivity, does giving them additional therapies actually affect better outcomes? So this is the study. Tu will be proud of this because she's like an acronym whiz. It took me several hours to come up with this because I've never liked those acronyms that just pull a letter here and there from a word. So this actually uses, with the exception of the and sign, every single first letter of the word, and it makes this great acronym called Predict DNA, and that's the title of our study. It's through the Translational Breast Cancer Research Consortium 040. The study accrued very quickly. It's been closed now. We have probably 5 to 7 years of follow-up on most of our patients. And excitingly, we're actually now analyzing the samples. There were some hiccups along the way. I think we all know of something called the pandemic. My move here from Hopkins to Vanderbilt also was a little bit challenging to get the samples all done. But this is 228 patients. It's across 24 sites. Really was the first of its kind to actually have a prospective validation study of ctDNA in breast cancer, with the express purpose of actually using ctDNA as the real kind of endpoint. The primary objective really is, can we just find a liquid PCR, as I'm calling it? But probably the more, I think, impactful endpoints are going to be these. We're also powered and have secondary objective to see whether or not, again, getting back to negative predictive value and positive predictive value, if these become positive at any point, does that herald return of metastatic disease? And importantly, if they're negative serially for, we had follow-up, I think, probably 3 years of blood samples, does that actually equate with long-term disease-free recurrence? Whoops, I think, did I skip? No, okay. So what are some newer technologies? Methylated DNA, so this is what we call epigenetics. So DNA is often mutated, or is always mutated, in cancer cells, but they also have different methylation groups on their DNA that's different from normal cells. And so DNA methylation and other what we call epigenetic marks are now being queried in ctDNA to see whether or not we can use that as another way to get more sensitivity from ctDNA samples, as well as perhaps even use that as a predictive way to see if patients are going to respond to therapy or not. This is a group that I've been involved with. This was in various abstract forms, have already been published, but essentially they're using what we're calling, again, getting back to the first case scenario, multiple cancer evaluation, or evaluation, I can't remember anymore, detection tests. So these are basically primary blood screening tests, as that case illustrated. And this is what I think is first needed. Do you get validation? And so I think if you can see here and familiar with area under the curve, these are pretty impressive data looking at across a variety of tumor types and all stages, including stage 1, 2, 3, and 4. We have not done any asymptomatic individuals yet, but this really tells us we can detect a lot of cancers at very early stages. So it gives hope that in the future, we will be able to detect cancers, maybe even at the earliest stage. Now, I have said to my colleagues, both at this company and across the industry, we still don't know if that matters, right? That's clinical validation. Clinical utility means if we found something, could we act upon it, and could it actually improve the lives of patients who may get cancer? All right, and what about metastatic disease? I'm just gonna go over this very quickly. Again, it's very clear that patients with metastatic disease will have higher amounts of ctDNA, which makes sense because they have higher tumor burden or number of cells. And historically, what we have now gravitated towards the field is that it's the qualitative aspects. So in breast cancer, as an example, again, we now know that if you draw a tube of blood and find a PIK3CA mutation, you can get actually now 2 therapies, alpelisib or capivasertib, I'm not sure I said that right, or TrueCap, which is an AKT inhibitor. Those have been companion diagnostics that have been proven in the trials that if you have these mutations, you won't always, but you can respond to these drugs. What people have not really gravitated towards, though, in our field is using the quantitative aspects of ctDNA. Just as I was showing you earlier, how in the adjuvant setting, we should be able to monitor whether a drug's working. That could potentially have a lot of utility for metastatic patients. And again, when I was back at Hopkins, we showed in a metastatic triple-negative breast cancer study that this was feasible. And so an old moniker that we use, plasma tumor DNA, basically this shows you how high the allele frequency, so how much tumor DNA compared to normal DNA. And I'll point your attention to patient 3. So at baseline, this patient had a brain met, and that's denoted here about 33.93%. Got her resected, and then that number fell dramatically. But unfortunately, as she progressed systemically and ultimately succumbed to her disease, the levels correspondingly went up. So we now have a lot more options for triple negative breast cancer than we used to. It used to just be chemotherapy, but we have things called antibody drug conjugates, immunotherapy, et cetera. And a tenet in oncology is that the first drug usually has the highest chance of working the best and longest. It's kind of like pruning a bush. Every time you go to the next line therapy, it's probably not going to work as well as it would have in first line. And that's because those cancer cells mutate and they develop resistance genes and mechanisms. So this is an antibody drug conjugate that probably many are familiar with. That's called Trodelvy or sacituzumab govitecan. The premise behind this is that these drugs take chemotherapy to the cancer cells. There's a molecule on the outside of the cell called TROP2. An antibody recognizes it. But unlike traditional antibody therapies where it's actually shutting down the cell by binding to that particular cell surface protein, these are what we call Trojan horse strategies. They just use it as a docking protein to get inside the cell. And once they're inside, the chemotherapies that are inert, these are these little molecules here, become activated and they blow up the cell inside out. And that's basically how you can get chemotherapy now targeted so that it doesn't actually go everywhere in the body, but just to the cancer cell. So this is a study that is now open at Vanderbilt and will be opening hopefully in a site near you in the future. But this is with Dr. Vanderbilt-Ingram, my clinical colleague. And we're testing the hypothesis that if we actually could get a baseline ctDNA, we're doing this with Guardant Health, and then after a couple weeks of getting the chemotherapy, taking another blood test, and Guardant has done these parameters that if it's greater than 50%, that means that patient isn't responding. And so we're going to change the sacituzumab earlier than they would at the first restaging scan. If it's less than 50%, you continue with treatment, and the control arm, we just do it the same old-fashioned way we used to do. So the hope again here is by moving sacituzumab, which is only approved in the second and third line therapy right now for triple negative breast cancer, if we move it up to what I'm calling 1.3 line therapy, can we actually get better responses, and can we get more patients with better outcomes using ctDNA as a guidance marker, if you will. All right, why this matters for geneticists and genetic counselors. This was actually a great case that was fairly recent, but it's one of these things now where we have these liquid biopsy tests, we get them, and then we see mutations, and we think, aha, we can target something. So in this case, a gene called BRAF with a very common mutation that we have drugs for. On the other hand, we saw this gene, which is a mutation that we see in lung cancers that become resistant to therapies. But it turns out, and particularly here in the Southeast, there are germline families that have this mutation that predispose to lung cancer. And so one might get fooled if you're looking at this like, hey, why is this EGFR mutation here? We actually have a drug that overcomes this resistance mutation called osimertinib, but one has to really look at that allele frequency, right? 50%, as many of you genetic counselors know, that's pretty much means it's in every single cell in the body, and it's dumping, all the cells are dumping their ctDNA, both normal and tumor. This is almost assuredly just coming from the normal cells. And this is really, these low frequencies, what's from that cholangiocarcinoma, gallbladder tumor. Very tricky, subtle things like that happen all the time. And this is why I'm so grateful to Dr. Pal and all the genetic counselors, Meredith, Katie Lang, who couldn't be here, about how important it is to have genetic counselors involved with our molecular tumor boards, and I think vice versa. So in the interest of time, I'm not going to read all these bullet points, but hopefully I've convinced you that ctDNA or liquid biopsies are here to stay. We've only really tapped begun to tap their potential for helping us guide clinical therapy. But as the last example shows you, we really need the experts on both the cancer side and the genetic side to really help interpret these things and make good clinical decisions. And I just want to acknowledge all the people in my lab, as well as collaborators, funders, and these are my very cute dogs, Mac and Cheese. Thanks, and I'm happy to take questions.
So thank you, Ben. That was phenomenal. I think a lot of us will have the question about early detection and ctDNA. So you're welcome your thoughts on that, especially with so many companies just.
So none of these have really been vetted out. As I was mentioning earlier, the difference between clinical validation and utility. Some have validation for sure, but none have utility. And I'm not sure we're ever going to get there, because to do a utility study for a primary screen, as you know, takes decades because it takes a long, long time to see the outcomes of an intervention in form of a primary screen. And this is what makes it so tough. At the same time, I think, and as we know, as we've discussed, there are really well-designed studies out there looking at these tests for high-risk patients, the people who have this T790M germline or BRCA1 or 2 or TP53. I think that's where a great starting point would be if we know that these patients are super high risk. Can doing ctDNA monitoring augment the screening that they're undergoing right now? And could that actually lead to a better outcome in terms of maybe even cancer prevention, but maybe even just saving lives because you catch it that much earlier? And I think most people would recognize that catching cancer early is really the key to curing that cancer. But for right now, I never order those tests. They're not covered by insurance yet. They might be because, again, they get more. All you really need is validation to really get coverage in many instances. And I think that one has to be very, very careful. I also think the tough part about this is, because I've had people come up to me after the fact, primary care physicians usually are the ones doing primary screening, not the oncologist. And so a lot of times they may not understand the difference between validation, utility, and they may see a test that looks like it's got publication data behind it that looks good. But I think that this is where we as a field really need to help educate our patients and our colleagues. What really can this tell us and what can it really help us? I always tell medical students and patients that a tenet of medicine is, and I'm sure everyone who went to medical school here knows this, don't order a test if it's not going to change your management. And I think that's the hard part with these tests right now. We don't actually know if this is going to make an impact if we try to change management.
Yeah, and it's unfortunate because a lot of the companies are going directly to the primary care providers and these executive health providers who can afford these tests to go ahead and order it, which, you know, we're hearing across the country. So.
Well, and I think the danger is as these tests also get more and more sensitive, there is a very real possibility that we'll detect something, but it's probably not clinically meaningful, meaning that as we all age, we all get a mutation here or there in our body. You know, I think this has really come out with clonal hematopoiesis, where we know in blood cells, many people in my decade of life, I'll be 57 soon, have mutations in our blood stem cells. And most of the times, those won't do anything in terms of leukemia. It turns out they may present other risk factors for other diseases. But that's kind of the hard part. Now we've shown in various scientific journals that we all probably get mutations in our skin cells because of the sun, and our esophageal cells can also have the first mutations that could lead to cancer. But the vast majority of patients will probably never get those cancers because cancer is an accumulation of multiple mutations in the same cell, and that takes usually decades. So this will be another kind of conundrum that we're probably going to face as these tests get more sensitive. Is that, yeah, maybe the negative predictive value gets better, but maybe the false positive gets worse. Although I think if we did serial measurements, that might allay some of those fears, because again, the quantitative aspects may allow you, and even the qualitative aspects may allow you to monitor someone without pulling the trigger of saying, oh, you've got cancer.
So there's a question kind of along the lines of what we're talking about from Beatrice Becker. Dr. Park, would you order an FDA-approved ctDNA panel, such as Guardant or Foundation Medicine, for a patient without personal history of cancer?
I wouldn't, because again, one, those tests are really designed just to detect patients with cancer. And I think I'm not even sure how that would be ordered without some insurance snafu, because if you're ordering it for a non-indication, the patient's insurance is probably going to deny it. A lot of these companies say you'll never backbill the patients. I think what's really true is, in my experience, is they will backbill the patients, but they'll never collect. But still, from a patient perspective, that's a lot of stress getting a bill for $1,000 or $4,000 and being told, oh, don't worry about it, we won't collect. So I've had some discussions with some of my colleagues in those companies, and you know, they're trying to be thoughtful about how to really get these into different use indications, but right now it's just not ready for that particular use.
Yeah, and you know, the other thing I've heard in the inherited cancer space is there are some studies that are going on, right? With TP53, there's a study across Canada that's now recruiting TP53, so leaf-Romani patients, and testing liquid biopsy, but in a responsible way under a study protocol. On top of that, the last I heard was NCI is going to be opening a trial focused on liquid biopsy with one of the commercial labs, I believe. That was going to start this summer. And we do have an ICARE case conference with a speaker that will be telling us more about that. And then in the UK, they have their own TP53 study as well. So
Yep.
I agree with you that in order to test liquid biopsy and like the utility of it, we must start with patient populations that are at a higher risk for cancer, right? Like otherwise we're not going to get outcomes, which is like a cancer diagnosis in order to really tell us, is this beneficial or not?
Yeah, we have to do the studies. One of my colleagues / mentor in this business is Dan Hayes at the University of Michigan. And I often quote him when he said somewhat famously and infamously once that a bad test can be just as dangerous as a bad drug. And I really subscribe to that philosophy. We have to, I'm a huge fan of this. It's been my career for the last decade, but I also can't be irresponsible and just say, just because I think it's great and works, we should all be doing this. I think where we should really be focusing on is proving that it's as great as we think and hope it will be. And that just takes more research and time.
So Brenda has a great question, which again, I think many of us share concerns. If a patient comes in with a positive ctDNA test without a personal history of cancer, is there any liability on the provider's end if they don't follow up with other tests or scans?
That's a great question, Brenda. And I think the field is too early to really be able to address that. I personally would say yes, which is another reason I wouldn't necessarily do this test in that particular situation. But we've even seen this in what we call the MRD or minimal residual disease space. Again, that's that space in the adjuvant setting where patients are all done for curative intent, but there are tests right now that you can order, and they actually are pretty good at positive predictive value, meaning if it comes up positive, that you usually will have a recurrence somewhere. But nobody knows if that's helpful. And so those are
but she's asking about no personal history. So it could
no, for sure. I would not do that. And I wouldn't do it in the other case either that I was getting at, because being positive, we don't know what to do with those patients in the primary screening space or even in the adjuvant setting. And so I think that that's where we need research on both fronts. They're really quite similar when you think about it. You're looking for microscopic disease, either with this primary screening test or in the adjuvant setting. But both right now, if you pick something up in the blood, you don't know what to do with it, other than now you think that patient has some sort of cancer somewhere in the body.
Yeah, and I guess the problem is many times the providers that are ordering these are being, informed by the companies that are offering these. And really the question of once they order it, what is their liability has not yet been addressed. I mean, maybe it has, I don't know, but like that's something that they should probably look into as they order these tests. I had another question, Ben, regarding that first case that we discussed, liquid biopsy. So this company is telling this patient, direct-to-consumer company, to get ongoing. Like, can this patient sue that company? Like, what about from a patient rights standpoint? Because that's just so wrong.
It is. I agree. I think it's very irresponsible. I don't think that that's something the company should really be doing. There's a clear conflict of interest, right? So to me, I think that that's something that should never be done, and really needs to be vetted with professionals who understand this space in this field.
So there's another question related from Brenda to Meredith. Can you repeat how you handled your case? Did you refer your patient to an oncologist? Noting that Ben was already involved in this case.
Yeah, we had reached out to Ben before we ever saw the patient. Katie and I had talked, we had reached out to Ben. So that was really helpful to have that understanding to not be able to not have to put a lot of weight on
these test results and take more of the focus onto
I actually
the
ended up
clinic.
talking to the not patient, the individual, because
Oh, yeah, you did.
Yeah.
Yes.
yeah, I dug up the old email, Meredith, and I had actually first pre-warned him of my viewpoints of that I just expounded to everyone, and whether if he still wanted to talk to me, I would be more than happy to. But I do find a lot of people, if they really want the test, doesn't matter what I say, they're going to get the test. Someone has asked my position on Gallery, and I don't want to pick on any individual company or test. I think the company's Exact has a test like this from a company they kind of absorbed called Thrive. Even the company that I'm working with eventually wants to do this, but I think good companies recognize the value of doing the real validation study. And I think it's hard because from a company standpoint, they're a business. What if they end up spending millions of dollars on a long-term multi-year study and disprove there's any utility? They've just shot themselves at the foot. So I think it's really challenging to get a company to say, hey, you need to do the real utility study, not just the validation study, because of those, I would call, conflicts of interest. So we'll see how the field evolves and gets shaped in the next few years, but it's there's no easy answer to this.
Yeah, but that brings up like a more broader point, right? From a policy standpoint, because in the US, you just said validity is enough sometimes for coverage, and
Yep.
utility is not the benchmark we use, which
Correct.
again, we all know we're bankrupting our healthcare system. So maybe these are some of the things someday that can be taken into consideration as we're just ordering tests that may not benefit patients.
There's a question about trials going on using ctDNA in high-risk clinic patients. The answer is yes. That's what Dr. Powell was just talking about in Canada, where some of our colleagues, and as you just mentioned too, I think maybe the NIH or NCI is planning on something.
NCI said, they told me last year that they're going to be starting something this summer, I want to say, but I don't have specific details in the UK. But is there a study that is available broadly looking in high-risk clinics? Not that I'm aware of. Ben and I have talked about this, but no company seems to, and again, for the reasons that Ben already mentioned, want to be involved in this type of study because, again, we don't know if it's going to benefit patients or not. Our hope someday is that, yes, it will. As the technology improves, as we get better, again, there are certain conditions like we all know about, especially on this call, Lee-Fraumeni syndrome. These patients have greater than 90% risk, and we can't remove organs to bring those risks down to a really low level either. So, we have, here. Sheila is on the call as well. So Sheila Rajagopal, who is a physician scientist at the NCI, focused on breast oncology, but also robust expertise in cancer genetics. NCI study will be through DCEG with Pyle Clincha, Sharon Savage for blood testing among LFS. So I did,
Cool.
I did recall correctly. I don't always recall correctly, and date is TBD.
There's a question in the chat about, using NIPS tests and finding what looks to be cancer in the cell-free DNA. So for those who are unfamiliar, maternal fetal medicine folks really invented this field about a decade before cancer folks did, where now you can literally draw a tube of blood from a pregnant mom, pregnant woman, and then get the fetal DNA sequence and look for anomalies. So you don't have to do amniocentesis or chorionis villus sampling, CVS, which obviously has some risks. We have run into this where we have actually detected ctDNA that is from the mom and during the process of this. And it is challenging because we don't know what to do. You don't want to scan the mom because the fetus is there. So these become very challenging cases. We don't have enough, I think, cases and evidence to know what is the best thing to do. And these are instances where I think using the best kind of clinical judgment and acumen available at a multi-tertiary kind of academic health center probably is the way to go and get some opinions about what to do. Those are really the so-called incidental findings that in this case can sometimes be really, really life-changing.
So Sheila has put in some comments. Speaking of NIPT testing, upcoming data will be available through the Identify study regarding accidental identification of ctDNA on test methods and screening recommendations, what to do next. So we look forward to that.
Yep.
And then Kathleen Munoz has a question. How do you address oncologists that are worried about false positive for trials that have ctDNA testing?
Yeah, I think no test will ever be 100% accurate, right? So we face this all the time in regular medicine. And that's kind of what I point to people is that sometimes we get false positives on a CAT scan or an MRI, and we have to kind of just be mindful of it. This is one of the reasons I created molecular tumor boards, first at Hopkins and now here. I think a lot of times if there's any question of how to interpret this and what it means, as you saw that T790M case, I think it really is to everyone's benefit to try to get some vetting with people who kind of know this space and live and breathe it. And I've made this mention on ICARE in the past, but we do have an international molecular tumor board if people want to sign up, because it's not just international, it's also community hospitals, other academic hospitals, et cetera. And we just have discussions about cases that people bring to us. It meets once a month, usually on the 4th Monday of the month.
And that is something that we can send out after the call, the link to that information as well.
Yep.
The other thing, as Ben just mentioned, so what is unique at our institution is that Dr. Park reviews every single tumor sequencing result that comes back to our institution. So us on the hereditary cancer side are privy to a lot of information that, you know, to guide, okay, well, what do we do next? What is the interpretation? So as I suspected, we are out of time. So we very much appreciate everyone attending. Thank you so much, Ben. We will definitely have you back again for more of the germline tumor stuff. And with that, I wanted to thank everyone for their attention. Again, thank you, Ben. And we will see you next time. And if anyone does have questions, always reach out to us and we certainly can connect you to Ben. And as you've seen, Dr. Park is always very open to addressing many of the questions that we have. So thank you, everyone. See you next time.
Thank you.